Marcos. Okay, our next speaker will be Dr. Brioschi, and he will be talking about sympathetic stress testing for CRPS RSD. Jeff, he's going to split this talk and the next talk in half, so you might give him a timeline. And we already know Dr. Brioschi.
Thank you so much. So let's talk about dystrophy. Thanks for this meeting in Greenville. It's a very nice meeting, and it's a pleasure to meet you here. And as I said, I'm from São Paulo University, and I work in a pain center and neurosurgery department. And we live very far from here. It's 6,030 miles away from, but it works. And this is an old photo of our São Paulo University. It's a complex with different specialties, and we have so much people. It's a public institute, and we help these people with what we can do, and with also using a high technology and in a public health. So thermography, it's important. It's diagnosis. Thermography is for follow-up treatment. Thermography determining outcome. He mapped the state of disease as showed by Dr. Schwartz, and it's an early adjunctive diagnostic for causes of pain. So you can do diagnose, follow-up, monitor the disease. But you must to do in a correct way, using a correct protocol for this. Because most important of thermography is that it's an innocuous exam. Innocuous. You can repeat all the time. It's easy to do this anytime you want, how many times you want. So the human body has lose heat by evaporation, convection, but radiation is most important, and it's what we are seeing with thermography. So we stood the sympathetic system, nervous system. It's a complex system involved with all the body and almost all the diseases, as the eyes and the skins and so on. So all the images are connected with sympathetic systems and the blood flow. Okay, so we have to do the image. We have to make the patient wait in 15 minutes before do the first image. Why? Because when you took off your clothes, you have a homogeneous image with your clothes that warm the skin, and we must wait 15 minutes to equilibrate with the temperature of the room. So it's very important to wait this time before do the first image, because so you have a false image, you have an artifact on this. So like the same way we use, we measure temperature, like oral temperature, thermography is different because we measure 36,000 points at the same time, and we can do this image. So the human body has a very symmetrical distribution, and it's not stop. Okay, no problem. And if you divide the human body, you see that distribution, thermal distribution, is very similar between left and right. This is a normal guy. So, and who controls it is the hypothalamus. It has a high precision on this control, and you have 0.2 degrees difference between the right and the left side only. after 15 minutes of equilibration. So the hypothalamus has a powerful control on thermoregulation. So to understand the thermography, it's simple as measure temperature, but you must to understand the physiology of thermoregulation and sympathetic system nervous. And this control is maintained by all the nerves, all the system, all the nerves, central and peripheral nerves. So when you have this image, a full body image, you're looking for asymmetries. So where asymmetric here? Here's symmetrical, but here's asymmetric. It's much more cold in this area and on this left. Most of our patients, we do full body image. When you do full body image, you have a complete, you understand better what's happening with the patient. No minds for me if the problem is only the foot. All the patients we do full body, because you understand better. You understand that's a problem here on lumbar side is different. And you see that's a much more high temperature on the shoulder, maybe correlated with myofascial pain. So when you do this, you understand better your patient, because most of the time he didn't say that it hurts other parts. The patients are most specific for to say what really hurts them. And sometimes we don't research for other parts, and it becomes a later symptoms. So you help him with the foot, and he says, "Oh, now is my shoulder, and now is my back." If you do the image, you see all this on the first time. So it's very important to do full body image, because you will see all the problems. Choose the most important, because here is the most difference is in the legs, or is the main complaint. But you have something here to treat it, here to treat it, and so on. In this case, it's a cold sign. It's a fibromyalgia patient with the panda eyes, you can see, and dystrophy on the right. It's very common. Most of these patients with fibromyalgia, sometimes we forget that they can have other things other than fibromyalgia. Because it's very common, they go to the physicians, they say, "Oh, it's fibromyalgia, and here's your medication." No, okay, this pain is fibromyalgia. No, it's very common, fibromyalgia with another things, osteoarthritis and so on. So the diagnosis of complex regional pain syndrome is a clinical diagnosis. It's not thermography. It's clinical. Most of the diagnosis must be clinical. Sure, you see the sensory system to looking for pain, hyperalgesia, allodynia, motor disturbance, dystonia, tremor, paresis, and autonomic pseudo-vasomotor changes. But the problem is that it's very difficult to recognition on early stage. And the early stage treatment is the point. If you do the blockage until 6 months, you have a good response of these patients, almost 80%. But most of them comes 1 year, 2 years, 3 years, 10 years after. And the diagnosis is very easy on this late stage, and sometimes it's not necessary to do thermography. So thermography is most important here on the early stage. And patients with myofascial pain syndromes, fibromyalgia, depression, patients that sometimes are involved in litigation, that it's very difficult to know if he really has fibromyalgia or complex regional pain syndrome, and elderly and also child. So it's rare, but it can help. So there are important things in complex regional pain is the false hallmark. False hallmark, if you see hypothermic asymmetric limb, it's not necessarily a complex regional pain syndrome. If it's hot or cold, it's very important to understand this, because there are a lot of situations that can mimic CRPIs. Acute trauma, post-traumatic injury, C-fiber mononeuropathy. I'll show you the next presentation a lot of examples of mimic examples of CRPS. diffuse hypothermia. So it's very common on orthopedia. They put the mobilization for 3 months with mobilization, you create a similar CRPS syndrome, and it's not CRPS. It don't have indication to do blockage. So it must be very careful, because these patients will not respond to blockage. These patients will do repetitive sympathetic blocks as necessary, and it's much cause more pain, no results, and a big problem. So it's necessary to separate this patient from the real complex regional pain syndrome, patient that has a sympathetic dependent pain from independent pain. And this is an example. You see it's asymmetrical. It's a cold limb left, but it's because he has a mobilization here. It's not necessarily a complex regional pain syndrome. How we know it? First, clinical signs and a cold stress test that I learned with Timothy, yeah? And we learned it 3 years ago and started to do it in Brazil, and we have a good experience with this. How we do this? We call functional infrared cold water autonomic stress test for sympathetic maintained pain. So you have the camera here in a tripod, moving the hands. So he has the suspicions on the left hand, and he put his leg on the cold water for 5 minutes, and we make the move of the 2 rands, the normal and the suspicion rands, and we see the response. So again, the camera showing the right hand and the left hand. You see, it's very simple. The patient see what is happening with his hand, because thermography has this thing that's very important. He saw and he understands what's happening with him. When the patient do thermography, I show to him every time the image to him. Oh, I have a problem here. Yes, you have a problem, a big problem, distension of the problem, and he understands better the treatment that I do after. It's why you do the block. Yes, because you have a cold limb, so it's very better to manage the treatment showing the pictures to patients, because the pictures are very simple to understand for the patients. It's very important to do, because ever show the image to them. So full body and show the image. And here's again the test, studying the limb. For limb, we put the 2 arms on the cold water for 5 minutes and start to measure. So for limbs, for upper limbs or legs is no problem to measure. So let's see. This is the hand, first image of the hand. The hand of the pain. When the patient has pain. So 13 seconds, 1 minute, 2 minutes in the end. Okay? So if the patient has a paradoxal response, you confirm that he has a problem in sympathetic system, because sympathetic normal response is vasoconstriction, not vasodilatation. If you put your hands on a cold water, it must make a vasoconstriction, not vasodilatation. So you confirm that he has a disturbance in sympathetic system, associated with pain, associated with allodynia. So patients with mobilization don't do this. There's no way to misleading this. There's no way to trick the physician with this. It's very objective. Again, this was the first image and the last image. Okay, it's another case. Okay, So the vasodilatation is very, very simple to see during the exam. And if you don't do the cold stress, you have a high sensitivity but a low specificity. And when we do the cold stress test, you have a more high specificity. This is a study of Niehoff from Netherlands. The American Academy of Neurology says that thermography is a resonant test to use in patients with CRPS. So since 1996, it is recommended by the American Academy of Neurology. Dr. Connell, that is here now, has a good paper showing the 72 sensitivity for cold water autonomic stress testing and 94 specificity for this, and with a kappa index of concordance of 0.69. When comparing patients with modified ESP criteria for CRPS, and Gulevich, also Connell, has another study with 93% sensitivity and 89 specificity. We are almost finishing a study at Brazil, São Paulo, and we saw that when the patient has no response to cold stress and do blockage, the blockage fail. So the blockage only has a good results when the patient has a vasodilatory effect. And the case that we don't have success is not because of the blockage, but it's because of other compartmental associated things with that patients, sometimes litigation or psychological problems not related to sympathetic function. Because after the blockage, if you repeat the exam, it makes vasoconstriction. But we must wait 1.5 months to repeat again. This is another case. So numerous somatic and neuropathic conditions present with signs and symptoms that mimic CRPS. The mimickers often reveal asymmetrical infrared asymmetries that lead to interpretation errors. Inaccurate interpretation of the infrared data may condemn the patient to repetitive sympathetic blocks and unnecessary therapeutic interventions, which eventually lead to therapeutic failure. She's a lady with edema on the right hand, pain, allodynia. But when we did the cold stress test, putting the normal hand on the water and filming this in the hospital, he is a doctor. This is the first image. Then this is a 50 minutes image, negative. But she was pain, edema. And the chief said, no, she'll do the blockage. It was in the first case. She'll do no results. So it's very important to do thermography to separate sympathetic mediated pain from non-mediated pain, because you will have much more success with this test. And there's no other test to substitute this. Only thermography can do this very easy, very fast, and very accurately. So this is a right indication for thermography. And sympatholytic blockage monitoring is also possible. So we do pre-blockage, during blockage, and after blockage. During blockage, it's possible to evaluate interventional pain procedures, like local anesthetic results in vasodilatation and augmented temperature, blood flow, so we can move during the procedure, show that it's in the right place, that it's working the procedure, verify the catheter right position, reduce X-ray exposition, and do in a more fast procedure, not spend so much time with the patient on the operative room, and confirm pain alleviation. Because imagine some patients, when you do the blockage, after blockage they say, no, it also hurts. I have pain, because they are involved with litigation. So during the procedure, you see, no, okay, it hurts. I respect you, but my procedure, it's correct. And I move, I document this. It has a legal wait for this. And I have this movie here